and clinical audit across eye care organization. Moving further with today's CQE session, I would like to invite panelists Dr. Gangan Dudeja, Dr. Chandrasekhar, and Dr. Mathew Kurian for the panel discussion on communication error, near miss, and documentation issues. I would also like to invite Dr. Nirmal Fredrick, sir, to moderate the panel discussion.
Thank you, Shweta, and welcome all the panelists and also the other faculty speakers who are here to join us. So we are, I think, behind schedule. So we'll try to take up as many questions as possible. So this panel discussion is on generally what the hospital perceive as challenges or pain points while preparing as well as during the implementation stage. So let me start with Dr. Chandrasekhar, who has helped many hospitals implement the NABH standards. He's been the coordinator for many Arvind Eye Hospital groups. Dr. Chandrasekhar, what do you consider as the common challenges in eye hospitals?
Thank you, Dr. Nirmal. See, basically, at the beginning, it is difficult to get all the statutory processes in place to make the management accept there is going to be a cost involved. So today, after 2 decades, all the statutories are good, and the hospital management also know it is actually going to help the hospital, and it's a legal requirement. Especially, having a pharmacist and all those things were not there. They used to have it only on the paper. The second is getting the mindset of the team. At the beginning, the NABH coordinator is the biggest villain. But once they get the NABH, they become, acceptable. But again, the second problem is sustaining what we have done. That is truth. That is the truth everywhere. And again, 3 months before the next audit process, be it accreditation or entry level, we have to revamp. And some of the things, very good things, For example, in a tertiary care where I am attached, all the 4 committees were helpful in getting the process being done. Because NABH coordinator alone cannot do anything. But he should be knowledgeable about everything to identify whether things going wrong. So first is the statutory and initial investment from the management mindset. Second is getting the team together. Once these things are done, no narcotic license, all those things will come under the statutory. If we have the statutes and a good team which is willing to work with us, and as Dr. Zamina said rightly, we have to write, because Dr. Nirmal also knows where they have had the Airways HR in one of the hospitals. They just copy paste all these external agencies. If they write, it did not be big and all. That's just how you should do intraocular pressure management. What are the processes? Then there will never be any problem. And it will take time for it to get fine-tuned. If these are the 2 important things, and getting the mindset of the people to do consistently. Third thing is not doing it only for the purpose of getting NABH. If that we do, after getting NABH, both the management and the teams, and sometimes even the NABH coordinator will start relaxing with just 1 week, they have a celebration. And again, after 2 years or 3 years, they will start all over again. And today I can tell you one thing, even in entry-level standards, the reference point is only NABH 5th standard, 5th edition. Whatever is applicable for entry-level, 5th edition explanation is the best, even for eye care. So this is something they have to keep. They can do at entry-level, but wherever it is possible, they can go to even eye care standards. First is the statutory, second is the human manpower, and third is consistency. This is what I feel, Dr. Nirmal.
Okay, thank you, Chandrasekhar. I think that sums up the challenges. Anything to add, Dr. Gangan? You've been assessing many eye hospitals. So what are the common challenges they face other than what Chandru initiated?
Sir, the common challenge I feel is they don't do their homework well. Because earlier when we started, let's say 10, 12 years back, resources were not there. And now the resources are there. That's what was the gist of my presentation, that go to the NABH website, the material available. So lots of hearsay. And an example I've been repeating multiple times, and I'll repeat once again. is two of my students from Netralaya, and they have practiced in same city in the same locality. And a fate of luck would be their NABH audit was within a gap of a week or two. Audit done, they had a common consultant, and then they're sitting together and blaming NABH for that. The same hospital I got NC, you didn't get NC, and they decided to call me up. And then during the course of call, I realized that one had applied under the entry-level category, and the other had applied under eye care category.
Thank you.
So things change. So I believe that the first thing is, when you are willing to put in so much of effort, time, money, and everything, the information is now available. Gather the right information and start. That's where hospitals make mistake. Like both of us are aware of that hospital in Rajasthan, where they decided to renovate the OT to modular, and the OT process got stuck. And for 3 to 4 months, their OT was not functional, whereas they didn't need modular OT for entry-level accreditation. So I think lots of things we get the wrong message and act on it without verifying that. That would be the biggest challenge. Whatever you are trying to do, any major change, please verify, please cross-check it is required to be done or not.
Yeah, thank you. We go to Dr. Mathew. Anything to add regarding the challenges? I understand the attrition issue is one challenge in a hospital like where you're working, as well as the corporate setup. So attrition is a challenge for many organizations. How do you handle this challenge?
We have struggled a little bit with the attrition. One is during the COVID lockdown, we had challenges. But subsequently, what we find now is that with my organization in Kerala, when job opportunities open up in the Middle East, attrition rate, forget 2% as Mandeep was showing, it can be even 50 or 70% because people just disappear over there. The salary structures being so attractive over there. Fortunately, there are a lot of training centers in Kerala itself, and we have to struggle to get trained people, but we will get freshers. And so we have to have a very strict or a very well-developed training method where, individuals are kept as champions within the organization and are able to mentor the newcomers. So at least 1 or 2 people in each function will be in that role and help us to overcome the challenge of attrition.
Okay. Thank you, Mathew. Dr. Mandeep, would you like to add something? You might also be facing a lot of attrition in your sectors.
Yes, but one point in attrition, actually, whenever we have small teams, even 1 or 2 people leaving, the percentages would reflect as high in the graph. Actually, it's so the small team. So the issue is the passing on the baton. It's like a relay race. So you keep because of the attrition, you keep dropping back to this level. So the effort has been to raise the baseline so that people moving on or people being transferred doesn't it should not be hampering. So that has been the target. So the other thing is involving the doctors, like even in this session, maybe ophthalmologist. So what usually we do is infection control and clinical audits, medical records, like the clinical part. We do try to involve them. The other parts, okay. So the idea is that the clinical team needs to have that sort of ownership. So unless it is thought of as ki quality manager ka hi job hai, and they will come out some one fine day and face the assessor, that doesn't work. So that is how we do. We tell them that we are only the teachers. We will not be facing the exam. On the day of the assessor, I will be just sitting in my office and relaxing. So that is how we proceed.
Okay. I think I can see Dr. Vijay Agarwal, the president of CAHO, in the panel. So we need to conclude the session. We quickly take a few questions from the audience Q&A. Something we have not answered there in the Q&A chat box. So one is from Dr. Geeta. Is police verification necessary for employee antecedent verification? Should it be done for all staff, or for which category of staff it needs to be done? So can anyone take up this question? I think it is related to the HR. If Sendil is here.
Yes, sir. Dr. Sendil here, sir. Sir, is it audible, sir?
Yes, yes, please go ahead.
Yes, sir. So police verification is not mandatory in all cases, sir. But in cases we cannot, where we cannot trace the origin of the documents, or where there is no verification or from the previous employee, letter from the previous employee, or in case if we suspect any pending legal issues, in that cases we need a police verification. And usually they tell workers, lower cadre workers or employees from other states where we don't know the origin, police verification is helpful in such cases, sir. Where we don't have an educational document, license document, that kind of workers.
Okay, yeah, thank you. Anybody to add to Dr.
Nirmal, can I
Yes.
just add, Dr. Nirmal? Yeah, I have had a situation where there was an NC saying that all the employees had to get police verification. Once the NC comes, it becomes difficult. But ideally, what happens is people who are in security, people who handle cash, wherever they need to be really monitored, better to go for a police verification. Today in our state, we don't have to write to the police station or anything like that. Online, we can submit the details and then wait for a verification to come. So once or twice, we have shown that as evidence. But we can take a letter when they join undertaking saying that there are no criminal cases or anything pending. That is the maximum we could do at this point of time. But anywhere there is going to be security issues or cash involved, then ideal to get a police verification. This is what we follow.
Okay, I think it's really heartening to know that the online situation is online portal is working. We did try for a couple of our employees, but we didn't get any acknowledgement or answer from the police department. So hopefully.
But for NAPH, if we give that, they will close the NC.
Okay, thank you. Any other inputs? So one more question is the manpower requirement for eye hospitals, particularly the GNMs. So what is the manpower requirement in critical areas and other areas?
Sir, I'll just like to add something to the previous discussion.
Yes, yes, Gangan.
So what happened is that of late when we are discussing that the police verification is not mandatory, many hospitals have just taken a way out and there is no antecedent verification. So let us put this way that the hospital has to verify antecedents of all workers and all employees. Police verification is not much, but they have to have a system of antecedent verification. We cannot say that we have just uploaded online and there is no verification at all. It's just an online upload saying that, we have just applied for.
No, absolutely.
That's
point well taken, because the organization has to make an effort to verify the antecedent, either from the previous employees or the college. And maybe as Chandru said, for critical areas like the cash handling and security, definitely from the police. Okay, so there are, yes.
Dr.
Yes,
Mandeep wants to add something.
Like Dr. Chandrasekhar mentioned regarding NC closure. So what I have seen is this police exercises mainly focus on NC closure. Nobody comes and checks it actually. So, so this verification actually never happens. So what is more important, as Dr. Senthil mentioned, is that at least get the previous employer to give a no objection certificate. Because I've heard of an incident where a doctor was involved in some financial irregularity and was hired with another hospital, and then they came searching for him. So it's at least get the previous employer to say, okay, we have a clear separation from this employee. So at least that much is done. But yes, when the NC is there, so we don't know. We have to go through the process, but nobody ever comes and verifies actually. That is the experience so far.
Okay, thank you, Mandeep. A couple of questions here, case scenarios. In one hospital, FFA consent was not taken and patient had anaphylactic reaction. So how do you go about this? This actually happened in one of the hospitals. So all of us are dealing with short procedures and rarely get any anaphylactic reaction. So what is the system in your hospital? How do we approach this case scenario? Gagan, can you take up this?
So we had a discussion, one of the talks which we talked about the consent in OPD. So FFA is one thing where you have to have the consent and the risk of reaction and anaphylaxis has to be mentioned and taken there. Plus, the injection has to be injected by the doctor and the nurse should be there with your crash cart ready at hand. So many a times it's some technician doing with no medical person in and around an FA machine that becomes a problem. And same thing goes with ICG. So a proper consent and a presence of person who can resuscitate and handle the situation, which will mean a doctor and a nurse. It may be a PG, it may be a fellow, someone. Whenever these procedures are being done, should be the protocol.
Dr. Nirmal,
Yeah.
I have had 2 occasions where I have seen a death occurring during FFA in a previous and one or 2 of my previous institutions. So it is a very difficult situation to explain to the patient's attenders, just like putting a drops. This consent can go against us if you have not taken a consent. It's a procedure where we are giving a dye. So it is mandatory to get a consent. If you have not taken a consent, even if you have done all the code blue CPR and everything, still it can go against us and it becomes very difficult to explain that. The patient can always say, if we had known that there was a risk. Sometimes there is always a question where they don't report history of allergies and all those things. Either we don't ask or they don't tell. So if the consent is not taken for a procedure, wherever you are giving an injection or something, then it will be totally against the institution only.
Okay. So many of these procedures, the patient come on their own without any attenders or relatives. So how do you tackle this issue? So of course they will sign the consent, but whom do we take as witness, or how do we inform the relatives if there is any issue?
Can I take it?
Yeah, please.
Yeah. Basically, this occurs when we do camp patients. When mostly in the camp we don't get the attender. So there have been very, very bad situations where patient is lost during surgery, before surgery, or anything like that. So currently what we do is, it actually just like that, taking a consent is no use unless you explain to them. In the campsite, mostly they come with some attender or other, and there itself the consent witness is taken, and from the patient, if they can sign, they will sign, or the thumb impression. That is the best way to do. In case they don't have an attender, a person may be coming along with the patient, so they can become a witness for that patient. And the third way we can do it, there will be one common person or an organizer who will be coming along. The third person can take that responsibility because it is very dicey. Otherwise, if the patient is coming to the hospital for planned surgeries, you can always ask the attender to come. You can take a witness, unless it's an emergency where it could be vision threatening or a life-saving procedure where the doctor or the superintendent or anybody in the hospital can give consent and go ahead with the procedure.
Can I add, sir? Dr. Sendil here, sir.
Yes, yes.
One thing is, sir told regarding government person's consent. Basically, the government person, either the district ophthalmic surgeon or the counselor, they come for verification whether the case has been done or not.
No.
And
Go ahead, Sendil.
yes, sir. And the consent taken from them may not be valid as to justify whether they had approved it or not. Instead, some camp coordinator or an association which has organized the camp for us in the place, they can give that consent.
Yes, Sendil, that's what I meant. The organizer is the person who organizes the camp. That is the third level. Second level, the attender, the relative of the patient will be accompanying them. We don't take from the government. They will not give
the
also.
approving authorities.
Yeah, not the approving. The government people will not give consent.
Yes.
Okay, I'm afraid we
you,
are running short of time, so we have to close this session. Maybe one last question from Dr. Debarati. Please explain nursing requirement for NABH entry level. I think there's similar question from Dr. Geeta also. So how do you describe this, or how do you close this non-conformance in entry level or eye hospital? This is probably one of the common non-conformances, that there is no GNM nurse in the critical areas, or the nurse ratio is less. Yes, how do we tackle it? I think we'll take the answer from all the 3 panelists.
I will take it first, Nirmal. I've seen this 7 times in the last 5 years in 7 hospitals. So currently, basically our original nursing requirement is for every 8 buds, we need 1 nurse. And supposing it's a place where you have admission, for every shift you need 1 nurse. So most of our hospitals, small hospitals, are daycare, number 1. So according to the requirement, it is 1 nurse per 8 beds. But fortunately in Tamil Nadu, the Clinical Establishment Act says for every 30 beds, 1 nurse is enough. So based on that only we are functioning now. Every 30 beds, 1 nurse, even for a 40-bedded hospital, 1 or 2 nurses will be enough in a daycare hospital. So all the 5 times have given this explanation quoting, because Clinical Establishment Act is that of the government. And of course, we say all the other things, we give the privileging of the paramedics only for assisting GA cases, only for giving parenteral medication, we use the nurses. This is how I have closed the NCs. Maybe others will have a different view. We take the Clinical Establishment Act requirement.
Right. So any other inputs?
Isn't there a requirement for OT staff also to have a nurse in the operation theatre?
Yeah, critical areas like operation theatre definitely would need a GNM nurse. So and other things, other areas, maybe as Dr. Chandrasekhar said, non-critical areas or what can be maintained under the assistance of the qualified nurse. Okay, so any inputs from the other faculty members? We'll quickly wrap up the session. Any take-home message or inputs?
One thing in closing NC, Dr. Chandrasekhar mentioned, is the number of beds and bed occupancy. Many hospitals which are functioning because they need a certain number of beds for XYZ reason, but they are utilizing only half of that. So, whenever we are doing NC closure, that's one thing which has to be taken, that the actual bed occupancy forms the basis of nursing requirement, not the sanctioned number of beds.
Yes, Dr. Gangan, in bed occupancy, in daycare, it will run to over 100% because we can accommodate more than 1 patient per day. So actually bed occupancy is only where patients stay. But as he says, where it is less, calculation.
But that's Arvind. But 80% of the hospital, it will be much less than the number of beds.
Yeah. Most of the small hospitals. Anyway, thank you so much for all the panelists for taking up this, joining us and taking up all these questions. I also wish to thank all the speakers, panelists for joining us for this interesting webinar. And thank you, Dr. Dr. Samina, for helping me with this webinar, getting the speakers and also coordinating with the panelists. And thank you, Shweta, for emceeing the entire 4 hours webinar session. Thank you so much. And I thank Kaho. I think Dr. Vijay Agarwal is here. Thank you so much for your leadership and guiding us, sir. And the quality professional wing, Dr. Lallu, Dr.